Hello and welcome to our 5th episode of Practice Pearls podcast, an educational podcast about menopause for clinicians in primary care and OBGYN.
I'm Amanda Clark, urogynecologist and menopause physician.
And I'm Kim Vesco, an obstetrician-gynecologist.
And I'm Tovi Anderson, a family medicine physician.
In 4, we discussed initiation of hormone and non-hormone therapy. Today we'd like to discuss a scenario of a patient considering discontinuation of hormone therapy.
And as promised, we will also discuss the evaluation and treatment of the genitourinary syndrome of menopause.
I'll start with my case. Ms. Parks is a 65-year-old woman who comes in to discuss a letter that she received from her insurance company recommending that she discontinue her hormone therapy. She has been taking estradiol tablets, 1 milligram daily, since she underwent a hysterectomy with bilateral oophorectomy for fibroids at age 45. She has tried stopping therapy a couple of times in the past and even tried an antidepressant, but she always has significant hot flashes. She says, "I just don't feel right when I stop taking estrogen." She states that she's studied the pros and cons and that the risks are worth it in order to maintain her quality of life.
This scenario is all too common. Medicare incentivizes health plans to discontinue any drugs that are on the Beers list of high-risk medications for the elderly. It is important to note that systemic, but not vaginal estrogen, is on the list.
As we've talked about the timing hypothesis, we know that we shouldn't start estrogen after age 60, but we don't have data to guide us about continuation of estrogen that was started early.
And we know that 25% of women are superflashers, women for whom hot flashes never seem to end. Many of these women will face the dilemma expressed by Ms. Parks. Tovi, could you tell us more about Ms. Parks?
Ms. Parks exercises moderately for 150 minutes a week. She has never smoked, and she has a glass of wine daily. She has mild hypertension, which is controlled on losartan. Her family history is significant for her mother having died at age 85 from complications related to a hip fracture. Today she appears healthy, and she reports no loss of height with aging. She has a normal BMI, blood pressure, and A1C. Her recent DEXA scan for bone mineral density shows a T-score of -2 at the hip as the lowest measurement.
So let's review the available evidence as it pertains to Ms. Parks. She's made it very clear that estrogen provides a quality of life benefit that is meaningful to her. She has made at least one attempt to use a non-hormonal alternative.
Since she has had a hysterectomy, she may take estrogen alone, and this does lower her risk profile for breast cancer.
We know that the risks of heart disease and stroke increase with age, and we don't yet know if estrogen started early remains cardioprotective as women age.
Let's consider her bone health. She has been on estrogen therapy continuously, and she hasn't yet experienced the rapid bone loss that always occurs at menopause or with cessation of estrogen therapy. If we stop her estrogen now, we can expect that she will lose 10 to 15% of her current bone mass. That's equivalent to about 1 T-score.
She doesn't have osteoporosis by bone mineral density testing since her T-score is above -2.5. I used the online FRAX calculator to determine her fracture risk, and based on FRAX, she isn't a candidate for osteoporosis therapy now.
This case illustrates a special opportunity with respect to osteoporosis care. She has a low bone mass at present with her T-score of -2. If we stop her estrogen, we can predict that her T-score will drop to -3 over the next couple of years, and she will then need osteoporosis treatment. For Ms. Parks, there's a clear benefit to continuing her estrogen therapy with respect to bone health.
So let's consider the options. Ms. Parks has no contraindications and no major health concerns that would be adversely affected by continuing hormone therapy. Continued estrogen therapy will delay the need for osteoporosis treatment. Switching to a transdermal estrogen would confer some additional safety benefits.
If Ms. Parks decides to discontinue estrogen therapy, how would you go about it?
Short-term studies have shown no benefit to weaning estrogen as opposed to discontinuing it abruptly. However, I think these studies may have had women wean too rapidly to have shown a benefit. If she chose to stop estrogen, I would switch her to an estrogen patch at an equivalent dose of 0.05 milligrams, and then I'd drop the patch dose every 6 to 12 months as tolerated.
If she prefers to stay on oral estrogen, I would first drop her dose to 0.5 milligrams, which is the smallest dose available as a pill. Going lower than 0.5 milligrams would require using a pill cutter or taking the estrogen every other day. Weaning is more difficult for women with an intact uterus who require progestogen because we need to maintain endometrial protection. The estrogen dose is weaned, but not the progestogen.
Another alternative is to stop estrogen and immediately begin one of the non-hormonal prescription therapies that we discussed in podcast 4. If we choose to discontinue estrogen therapy, I would start her on an oral bisphosphonate to prevent the rapid bone loss that occurs after estrogen cessation. This represents use of a bisphosphonate for prevention of osteoporosis, which is an FDA-approved use of the drug, but one that is not addressed in treatment guidelines. Data shows that starting bisphosphonates upon cessation of estrogen will prevent the rapid bone loss that is associated with menopause.
If she decides to discontinue estrogen, I would counsel her about future development of vulvovaginal symptoms. The time course for symptom development is variable, occurring weeks or even years after estrogen cessation.
So let's transition now to a discussion of the genitourinary syndrome of menopause. This will help provide us with guidance for how we would evaluate and treat Ms. Parks if she develops genitourinary symptoms after discontinuation of estrogen therapy.
I'll start by presenting one of my cases. Ms. Lee is a 56-year-old woman whose chief complaint is dyspareunia that has been worsening since her menopause at age 51. She's been sexually active with her husband for over 25 years. She reports no loss of interest in sex, but states that pain with penetration has become progressively limiting. She's been using a lubricant for a few years, but even with lubrication, she still experiences pain. She doesn't volunteer any urinary symptoms, but upon questioning, she reports that she has to get up at night once or twice. She urinates more often than she used to, and she has to pay close attention to the location of bathrooms. If she can't get to a bathroom quickly, she may lose a few drops of urine before she makes it to the toilet. She denies leaking with coughing or sneezing, and she had her first ever urinary tract infection about 6 months ago.
This is a classic presentation of the genitourinary syndrome of menopause, abbreviated as GSM. What we used to call symptomatic vulvovaginal atrophy has been renamed to GSM and includes a pretty long list of potential symptoms: vulvovaginal dryness, irritation, soreness, dyspareunia, urinary frequency, urgency, and incontinence. More than half of women have these symptoms and find them quite bothersome. Women with GSM are also more prone to recurrent UTIs.
It is incumbent upon us to ask our patients about GSM symptoms because studies show that few women report them to their healthcare providers. The good news is that we have safe treatments that work to alleviate a lot of silent suffering.
I find that it can be very satisfying to treat GSM. It is one chronic condition for which we can make a meaningful difference. Patients are very appreciative of their newfound comfort and often the restoration of their sex lives.
So, Toby, how do you approach the workup of GSM?
This is how I start. The diagnosis of GSM is made by the presence of symptoms in a postmenopausal woman and the exclusion of other vulvar and urinary conditions. In order to rule out other causes, I'd also inquire about symptoms of dysuria, vulvovaginal itching, increased or malodorous discharge, and abnormal vaginal bleeding. On the pelvic exam, I may be able to see signs of vulvovaginal atrophy, but my primary goal is to rule out other causes of her symptoms, such as yeast infections, bacterial vaginosis, vulvar dystrophies, such as lichen sclerosus, and vulvodynia.
I think it's important to emphasize that the physical signs of vulvovaginal atrophy can be mild and nonspecific, even when symptoms are quite bothersome. The purpose of the exam is to rule out other causes.
As estrogen levels diminish, the vaginal epithelium becomes thinner and less elastic. Vaginal blood supply diminishes, and there is less lubrication. On exam, the classic changes would include pallor and/or erythema, or both, sometimes petechiae, and a decrease in secretions. Using a paper strip to test for vaginal pH, there would likely be a rise from the 4.5 that we see in women with premenopausal estrogen levels to a pH of 6 in a postmenopausal woman who is not using estrogen therapy.
Signs of lichen sclerosus include white epithelium, fissuring, and resorption or agglutination of the labia. Lichen sclerosus is usually accompanied by symptoms of intense itching.
When women report dyspareunia, I always test for vestibulitis, now called provoked vestibulodynia. This condition is commonly overlooked. The vaginal vestibule is the tissue at the junction of the vagina and the vulva, just outside the hymeneal ring. The vestibular tissue can become exquisitely tender to light touch, a local allodynia.
The diagnosis of vestibulitis is not made by visual inspection. The Q-tip test is diagnostic. The Q-tip test involves lightly touching or rolling a small cotton swab along the vestibular tissue. If vestibulitis is present, touch with a Q-tip elicits marked pain. Applying topical lidocaine in a 2% gel or a 4% liquid will ablate the pain within a few seconds.
In patients with vestibulitis, lidocaine may also be needed to perform a speculum or a bimanual exam due to exquisite tenderness with any pressure at the introitus. Topical lidocaine can also be used by patients with vestibulitis to relieve pain associated with intercourse.
To assess for levator spasm as a cause for dyspareunia, I press on the levator ani muscles to check for tenderness. I also do a bimanual exam to assess for cervical motion tenderness and other structural abnormalities.
After examining my patient, I can report that her exam is essentially normal, other than mild dryness, mild atrophic changes, and an elevated pH of her vaginal secretions. I didn't do a wet mount exam because nothing in her history or exam suggests a vaginal infection. I also asked my patient to do a Kegel squeeze to contract her pelvic floor muscles in order to help me identify the location of the muscles. She can readily contract the muscles, and upon palpation, these muscles aren't tender. I use this part of the exam to instruct her on how to perform a Kegel exercise, as contracting the pelvic floor may help to manage her urinary urgency.
So, to summarize, your findings on examination don't suggest other diagnoses to account for her symptoms. She has been postmenopausal for 4 years and has classic symptoms, so the diagnosis is GSM.
She is already using a lubricant with sexual activity, which is the recommended first-line treatment. There are many over-the-counter options for lubricants, and she might try another product. The most common are water-based, but there are also silicone and oil-based options.
Water-based lubricants are less messy, but they're short-acting and may require reapplication. Silicone lubricants are long-lasting, but a bit sticky to wash off and may stain clothing or linens. Oil-based lubricants such as olive oil and almond oil are inexpensive and easily available, but should never be used with condoms. The oil can degrade the condom.
While lubricants are intended for use during sex, moisturizers are intended to help with dryness during daily activities. Women with GSM may benefit from using both.
On the Practice Pearls podcast website, we've provided a link to a handout that we created to guide women in selecting lubricants and moisturizers.
When lubricants and moisturizers are insufficient to relieve pain with intercourse, low-dose vaginal estrogen therapy is the next step and the most effective treatment for GSM.
Topical therapy is applied locally to the vulva and vagina to directly target the affected tissues.
Vaginal estrogen comes in several forms that include a cream, a ring, an ovule, and a tablet, all of which have similar effectiveness. All of these options, except for the estradiol ring, are prescribed nightly for 2 weeks and then twice weekly. Symptoms usually begin to improve by week 2, but 6 to 12 weeks are required for full effectiveness.
Vaginal creams that contain estradiol or conjugated estrogens were widely used as the first available product. The cream is dispensed with a vaginal applicator that has dose markings. Some women find the cream to be messy and the applicator to be difficult to clean.
A lot of my patients prefer to apply the cream to the vaginal opening with their finger as an alternative approach.
The vaginal tablet and a new vaginal ovule contain estradiol, and they avoid the messiness of creams. The tablet comes with an applicator to insert a tiny tablet high in the vagina. The ovule is a mucoadhesive capsule that doesn't require an applicator. The ovule is inserted into the vagina with a finger about 1 inch above the vaginal opening.
One additional option is a small vaginal ring with a slow release mechanism that is retained in the vagina for 3 months. Women can insert and remove the rings themselves, but the ring can also be placed by a clinician for women who lack the dexterity or mobility to insert a vaginal therapy themselves. As we mentioned previously, it is important to distinguish between the low-dose estrogen ring called estring from the systemic dose vaginal ring called Femring.
Most vaginal estrogen formulations don't cause serum estrogen levels to rise above those that are normal for postmenopausal women. Low-dose vaginal estrogen therapy does not typically stimulate endometrial proliferation, so women don't need to use a progestogen while using low-dose vaginal estrogen therapy.
The safety profile of low-dose vaginal estrogen is very different from that of systemic hormone therapy. But unfortunately, there have been no prospective trials beyond 1 year to demonstrate long-term safety. We do have 2 large observational studies of low-dose vaginal estrogen, and these have shown no increased risk of any of the chronic diseases that were associated with systemic estrogen use in the WHI trial.
Due to the lack of long-term prospective trials, the FDA requires that the package insert of all vaginal estrogen products contain the same black box warning that is used for systemic estrogen products. There is expert consensus that low-dose vaginal estrogen is much safer and that the black box warning is inappropriate. There is a national initiative to provide evidence to the FDA to support removal of the black box warning from low-dose vaginal estrogen products.
The black box warning does cause a lot of anxiety for our patients. I try to alert patients when I write the prescription, but I still get a lot of phone calls from concerned patients.
Beyond estrogen, we have 2 non-estrogen alternatives for GSM. One is intravaginal DHEA, dihydroepiandrosterone, also called prasterone. DHEA is metabolized within vaginal cells to estrogen and testosterone. It is available as a vaginal suppository which is inserted daily using an applicator.
There is an oral option for women who prefer to avoid a vaginal product. It is another selective estrogen receptor modulator, or SERM, named ospemifene. It selectively acts on the vagina but not on the endometrium.
When considering cost, only 2 of the options that we've discussed today are available as generics. Those are the estradiol vaginal cream and the estradiol tablet.
A special circumstance to be aware of is that of breast cancer survivors who are using aromatase inhibitors. Aromatase inhibitors such as anastrozole and letrozole are designed to block all peripheral conversion to estrogen, dropping serum levels to 0. Prescribing even the lowest dose of vaginal estrogen will circumvent the purpose of an aromatase inhibitor.
Women taking aromatase inhibitors often develop severe vulvovaginal symptoms and debilitating dyspareunia. Use of topical lidocaine paired with silicone-based lubricants has been shown to be very effective for these women.
For breast cancer survivors who are not taking aromatase inhibitors, low-dose vaginal estrogen may be considered in consultation with the woman's oncologist.
For Ms. Lee, I would prescribe any of the low-dose vaginal estrogen products according to her preferences and any formulary restrictions of her health coverage.
For her urinary symptoms, I would expect improvement with estrogen therapy. Additionally, I would suggest that she do Kegel exercises, and I'd schedule a follow-up visit in 6 to 12 weeks. I'd ask her to complete a bladder diary before that visit. If her urinary symptoms persist, then I'd continue the workup of her lower urinary tract symptoms.
We've covered a lot today, and as you may have guessed, we like to talk about menopause. We have a lot to say about the many options available to women to help their menopausal symptoms.
To recap our discussion, vulvovaginal and urinary symptoms, or GSM, are very common symptoms after menopause.
We have several treatment options for GSM that are safe and highly effective, including vaginal lubricants, moisturizers, and low-dose vaginal estrogen therapy.
We know that many women continue to have bothersome hot flashes for many years after menopause. There's no strict rule for stopping hormone therapy at age 65. Instead, we recommend careful consideration of a woman's individual benefits and risks as the basis of shared decision-making regarding continuing or stopping estrogen therapy after age 65.
And now it is time to wrap up our discussion.
This is Amanda Clark
and Kim Vesco
and Tovi Anderson.
Thank you for listening to Practice Pearl's podcast, Menopause.
All cases appearing in this work were developed to highlight common clinical scenarios. Any resemblance to real persons, living or dead, is purely coincidental.